Dear colleagues, welcome to our monthly dialogue. Welcome to our Socratic conversation. Uh, dialogues are live streamed in X and then posted in X and YouTube. So the access to our dialogues is very straightforward. Today is a special dialogue because typically our dialogue is with a guest, a top cardiologist. We have guests from the 5 continents, and typically the dialogue is with our guest. Our guest is the protagonist of the dialogue. Today is an exception. Our protagonist today is the European Society of Cardiology, the largest medical society in the field of cardiovascular medicine. Of course, we love the European Society of Cardiology, and today is a sort of celebration during this dialogue of the society. And the celebration will be with 3 leaders of the European Society of Cardiology. Tom Lüscher, the president of the society, who will reach us in the next few minutes. We have Ulf Landmesser, who is the chairman of an important committee, the Guideline Committee, and Tom Guzik, who is editor-in-chief of cardiovascular research and also the chairman of the Congress Program Committee, a very busy man. Let's start. As usual, dialogues are very interactive. If you have questions, please write it in the chat, and we will ask you to ask the question directly, but please write in the chat what is your intention, your question. Traditionally, dialogues are very interactive, and today will be more interactive than usual because we have 3 guests and not 1. So please stay with us and participate, ask questions. I'm sure that what we are going to say will generate a lot of curiosity and interest. And let me start with Ulf, Professor Landmesser, Professor of Cardiology in Berlin. You know him as top scientist in the field of cardiovascular medicine, but today he's here as chairman of the Guideline Committee. Ulf, let's start from the past. It's a fascinating story. What can you tell us about the past of the guidelines of the European Society of Cardiology? How did this start? Please, Ulf.
Yes, Filippo, thank you very much, first of all, for the kind invitation to the dialogue. I think the guidelines of the European Society of Cardiology have been a very important initiative developed, I would say, over the past 30 years. We can currently do from the ESC 4 guidelines per year, and it has really become more and more sophisticated, I would say, regarding the in particular the assessment of evidence. So what I would say in the development over the past 30 years, we have covered, of course, the main topics in cardiology. We have also, we might come later to this, new topics every year. Also at the ESC Congress this year, we will have first guidelines for several topics. So I think we are expanding as cardiology is expanding to not only cardiovascular disease alone, but also to the bridges, to mental health, to nephrology, to oncology. So I think the guideline very nicely reflect also the clinical development of cardiology. What I always think it is fantastic that we have so many experts contributing to the guideline that are doing this on a voluntary basis over the task force that works for 2 years. And what I would say regarding the development, from my point of view, the quality of guideline is constantly increasing regarding, for example, in the recent guidelines, we have tables of evidence, and this has been one of the principles that is more and more stressed, that we try to even professionalize the way how evidence is assessed and how it's also presented in the guidelines. So the recommendation, as you are all very well aware of, have different levels, and also the evidence grading has different levels. And this has been refined recently. So we have published in the European Heart Journal just a few weeks ago 2 important documents that actually refine the way how evidence is assessed and how that leads then to different levels of evidence in the guidelines. So I would say the assessment of evidence has been more and more advanced, and also the presentation of how that is done regarding the evidence tables. And I would say also the topics of the guideline are reflecting the expanding field of cardiology. So we will see at the ESC Congress, for example, the first consensus document on mental health and cardiovascular disease. We will have a first guideline on myocarditis, which I think is an important topic in clinical practice. So we are more and more expanding for recommendations for clinical practice.
Well, thank you, Ulf. I think that these 2 documents are indeed extremely important because everything in life can be improved. We accepted the level of evidence for many years, but then we felt, okay, perhaps we can further improve our stratification of the level of evidence. Can you tell us what you think is the major novelty in this new level of evidence, and the relation between the role of original studies and meta-analysis? Not all meta-analysis are born equal, by the way.
Yes. So I think what is really more clear due to these documents published in the European Heart Journal is that we have now for treatment and prevention evidence levels A, B1, B2, and C. And so the evidence level A, for example, can now not be only trials that just made it to statistical significance. So you have actually a certain level of statistical significance that you need to reach in order, for example, to come to a class A recommendation. And the thinking behind is, of course, based also on the contributions of our excellent methodologists in the Clinical Practice Guideline Committee, Peter Jüni, Colin Bagent, and others, is that there is, so to say, the chance that you are wrongly thinking the trial is positive, of course, is less if the level of significance is higher. And I think this in the documents has been very nicely alluded now. So what kind of statistical significance level you need to have in order to be sure to give a level of evidence A. So it's more strict in a way now. It will be more difficult to reach the level of A, but then it's evidence that we can consider really very, very unlikely that it will be changing. So what we have had in the past, sometimes a rather good level of evidence, and then new data coming up that changes actually the evidence from recommended to not recommended. And I think this will be very unlikely to happen in the future with the new evidence grading, because if you have a level A evidence, it's almost impossible that this will change over the future. So it's very definite evidence. So I think from my point of view, that is for the task forces, but also for the interpretation of the guideline. If you have a level evidence A, you can be very sure that's very consistent evidence, unlikely to change. And also level B1 is actually a very strong level of evidence now. And if you come to B2 and 2C, you need to consider the evidence level is not so strong. So that I think can be seen more clearly now in the new grading of the evidence.
Thank you, Ulf. And I invite all of you to read these 2 documents we have recently published, and you will really experience reading these documents what Ulf is telling us, that the evidence based of our guidelines with this new stratification of the level of evidence will be even stronger. Now, let's change topic from guidelines. Another successful story of the European Society of Cardiology is the annual congress. Tom Guzik is the chairman of the Congress Program Committee, another big responsibility within the European Society of Cardiology. And Tom, what about the past of our Congress? How all this started?
Thank you, Filippo, and thank you for a concept of a dispute and discussion with the European Society of Cardiology, and it's an honor to represent part of it. And I would say that history of ESC Congress is actually mirroring very well history of our society in general. The idea emerged immediately after Second World War, so really it is a very, very long-standing concept. And it's interesting to observe how from a small congresses organized by local national societies, as the Congress was developed in the 50s. The first Congress took place in 1952 and was actually chaired by Sir Parkinson, of course, from the Wolf Parkinson White syndrome. So, it was a great sort of initiative, but still very limited and very slow. And over the years, it has grown to the most important cardiovascular and cardiology event worldwide, which I think shows great determination of cardiologists throughout Europe and throughout the world to meet and work together. It is very interesting because initially the Congress between 1952 and 1988 was organized every 4 years by national cardiac societies in different countries that co-funded a European Society of Cardiology. And in 1988, a concept has been created that actually, progress in cardiology is so fast that we need to meet every year. And since then, we've been meeting yearly. And from 1988, the first Congress in Vienna, we were actually accumulating larger and attracting larger and larger groups of participants with really record numbers just before COVID and then in London. In London, I have to say, we have seen over 34,000 participants overall. We are now developed the Congress into an on-site and online Congress that we will be able to maybe discuss a little bit further. But it's actually quite interesting how the participation, submission of abstracts was shifting between different cardiology conferences worldwide, and how ESC Congress has been growing and growing in some way exponentially, and bringing true sort of pride to our society. And I think that there is a lot of very valuable lessons how our specialty is developing that you can learn by observing the Congress itself. For example, in the Congress now encompasses not only a very large number of delegates from various countries. In London, for example, we hosted people from 174 countries. So in fact, we are truly a global society. But also, I think equally important, we are actually attracting not only cardiologists. We have a lot of participants who are researchers, who are nurses, allied professionals. We have a very large industry representation. We have large representation of young future cardiologists and trainees. I think all of this shows how our society is, where the future of our society is placed. So I think it's an amazing and wonderful history. And I think, along with this, with development of cardiology in Europe, we are also expanding our scope. And as we will discuss, we have for many years organized ESC Congress only in a few selected cities throughout Europe. But now capacity has increased in various places across European Society of Cardiology area and Europe itself. And we are able to visit new places and offer our participants new experiences.
Tom, what about the geographical composition? You're right, we are an inclusive society and the participation is global. But over the year, you think that the geographical composition changed substantially for the Congress, or has been more or less stable in the last years?
So the geographical composition changes very sort of flexibly. And while quite a lot of participants are coming from Europe, with every year we see increasing number of participants from outside Europe, representing the global footprint of the ESC. And for example, in London, we had top 10 countries that were represented. included in the order that I have it written down here, was of course UK, because host country is always very highly represented, but on the second place United States of America, then Germany, then Italy, Japan, Switzerland, Netherlands, Spain, France, and then China. And we have really year to year increasing interest, especially from Asia, including particularly Japan and China.
Thank you, Tom. One more question is about the other congresses, the congresses of the associations. I think this is relevant in the life of our society. We have associations, and the associations have their congress, prevention, arrhythmias, heart failure, and so forth. Do you think there's competition between these congresses and the annual Congress of the European Society?
I want to think that there is no competition, because if there was, that would be not good for either side. And I think that I think firstly our subspecialty congresses are representing the ESC federational structure, and the fact that our society is unique worldwide, because we are actually a federation of these different associations, and that is big part of our strength, and therefore the subspecialty congresses are part of a very, very important activity for us. And I think that having regular meetings with representatives of different subspecialty congresses, it's very clear to me that the scope and the main focus that we put on individual congresses is relatively different. For example, the main congress, we want to bring everyone together. We don't want to just separate everyone into small sub rooms where you do not meet other specialties and you just stay within your own relevance. And that's why we try to ensure that a very important place in the ESC Congress are actually areas where people can meet, can interact, discuss interdisciplinary concepts and interdisciplinary ideas. At the same time, of course, during the main congress, we do present trials relevant for each subspecialty. And I think that the high interest of ability to present these trials to such a broad cardiology representation from the world is the most attractive aspect of our global congress, as opposed to the subspecialty congresses. So I think these activities are truly complementary, and I do not see very significant, you would say, competition internally for these aspects. And I think the attendance and the fact that our subspecialty congresses are very highly attended, and that is so far has not been impairing attendance of the main congress, is also evidence of that.
Yeah, well, I fully agree with you. And the image I have in mind is the following. This is not like a pie. In this case, the more slices you add, the smaller they become. No, it's not the case of a pie. Here, it's like a muscle. The more you exercise the muscle, the more you have good hypertrophy, so to speak. So it's not a pie to make in smaller and smaller slices, but it's a muscle. We keep exercising, and the muscle becomes more powerful and positively hypertrophied. I see Ulf raising his hand. Ulf, please.
Yes, Filippo, I just wanted to follow up on your very important point. I think we see that cardiology, of course, is getting increasingly specialized in electrophysiology and interventional cardiology, heart failure, imaging, and so on. And that's also reflected in the organization of the ESC and the increasing importance of the respective associations. But I think if you look at these congresses, they are all in the range of 3,000 to 5,000 participants. And as Tomasz mentioned, ESC is far beyond 30,000. So clearly, we are able to attract all the different subspecialties in cardiology to the ESC Congress. And I think another thing I observed is that all the subspecialties, if it's heart failure, if it's electrophysiology, if it's intervention, prevention, they try to present clinical practice changing trials at the main ESC Congress. And I think that's also very important that we have keeping our cardiology together as one subject with specializations, but ESC is a great way for everybody to also learn about the new developments in all the different areas.
I think that to complement what you just said, Ulf and Filippo, I think that the general key components of the ESC Congress that are revolving around the trials, as you mentioned, and every year we present around between 40 and 50 hotline trials, practice changing large trials that really then affect the guidelines, and hopefully they fulfill the p-value criteria, but also the guidelines itself. The ESC Congress is the place where we are presenting guidelines for our community. But I think what is really great is that we encompass, and over the years we started encompassing this more and more, that to just gain knowledge and information, we don't need to come to a Congress anymore. I mean, we can read this in the European Heart Journal, we can read this online, we can follow certain people on social media platforms and learn information that we can obtain. I think congresses such as the ESC Congress, Subspecialty Congress, are an opportunity to directly interact. And ESC Congress is built in a way to enhance and sort of create multiple layers and opportunities for interaction. So every participant of the Congress has a chance to interact with the top trialist, with the guideline author, and ask their direct questions, discuss the issues, and put them in clinical context. And I think this is the unique role of the Congress that makes it very valuable.
Thank you, Tom. We have a large, inclusive, excellent audience as usual. In particular, I see two raised hands. The first is from Professor Libby, Peter Libby, who is executive editor and one of the founders of the European Heart Journal. Peter, please, your question.
Well, first of all, I want to congratulate the ESC on the guideline process. Ulf, coming from North America, I would say that my fellows and colleagues often view the ESC guidelines as more user-friendly than the American guidelines. And the second point, I certainly don't see competition between the US meetings, the college and the EHJ and the ESC. Actually, it's not a contest anymore. I think the tide began to turn after the 9/11 attack in New York, in Washington, when people were afraid to come to the US. And then they realized they didn't have to come to the US because the ESC meeting was becoming scientifically really at parity, and now is at least at parity. And now, because of the policies of the current administration in the US, people are afraid to come because they think they might not get in. So my message to Europe is spread your wings. This is the time when science is under assault in certain places in the world to really take off and soar. And so count me in.
Ulf, any comments?
Yes, if I may, thank you very much, Peter, and I'm very happy to hear that, of course. And one of the aims in the, as you mentioned, in the guidelines has been to make them more user-friendly in a way, and their important feature are the figures. So I think the graphics of the guideline really are now heavily considered and have improved, I think, and thanks to Thomas at the ESC Congress, we will be able to really open the Congress in the beginning with the new guidelines. So it's always a highlight. I think the other point we are now working on, and there has been the release of a chatbot to use actually the guidelines to make them even more user-friendly so that you can actually get the information that you want as fast as possible. And I think these are things
and I have to say that I have asked this chatbot some very, very inconvenient and difficult questions, and it has answered correctly. So I'm impressed by the chatbot.
Oh, that's very important, Tom, that we actually tested the chatbot.
Yes.
So that would give wrong answers. That would be very difficult.
I gave it very difficult tasks.
Okay.
Well, we have a very active audience. Eva Gertz, please ask your question.
Yes, thank you. I think it's very important, the development that I've seen the last couple of years, where the focus has, although there was still like a theme for the Congress, the focus was also on guidelines and interpretation of different parts of the guidelines, because it's not only important to issue guidelines, it's important to follow up and help implementation of guidelines so that they are meaningful to what is really happening in our member countries. So so that was like a question then to Tom, if what are you planning to do? I think it was global health that was like the topic for the upcoming convention. But is it going to be more thematic, or are you going to stay with the guideline topics and try to falsify how they can be implemented?
So I think that one doesn't exclude the other. And I think that, you know, the aim for choosing topics and why the Congress, since a number of years, is using Spotlight for the Congress as a very important tool to kind of also use for marketing, for visibility of the Congress, is that we always tend to try to analyze the new trends in cardiology and pick the spotlight that reflects these trends. And therefore, it becomes very sort of natural that both guidelines and trials are actually reflecting this trend, because you know, we wait sometimes. For example, we will announce the next year's spotlight during the Congress very soon, and you will see that, you know, we have kind of waited with this topic that we chose for the next Congress in Munich because we thought there is not enough body of support within the guidelines and within the trials, and we need that. The way that all of these elements are integrated is that all the educational sessions as well as trial sessions, for example, within the Congress in Madrid, for example, where our main topic is global health, and we are actually going to have a session with trials with global health significance as one of our highlights on top of the other aspects. We will have sessions during which specialists from different countries will be discussing how they are implementing ESC guidelines in different areas. So, for example, how they implement guidelines in Africa, because our guidelines are reaching African continent as well, and what obstacles they see in this regard, sort of leading us towards a question maybe to Ulf, who is already raising the hand, you know, do we need global guidelines? So we are incorporating the Spotlight theme into all of the elements of the Congress, but we do not forget our Congress is for practicing cardiologists in primary place, and they come there to learn and interact with trialists and guideline authors and guideline content. And I think that is a unique capacity. I hope it answers your question. It's not one or the other. It's how to ensure that we actually merge them and we use the Spotlight to attract people to the most attractive and popular areas of cardiology at the moment.
Thank you, Tom. Ulf, you raised your hand.
I just wanted to comment also to the question of Eva that Tom in the program has actually given a very significant spot to the guidelines. So they will be presented in the beginning, but then we have sessions where different aspects from guideline task force members are presented. And then we have also clinical cases sessions together with the guidelines. So I think there is, from my point of view, very intense part of the program actually reflecting the interpretation of the new guidelines and also clinical practice cases. So I think that will be very well reflected.
I'm trying to make sure that Ulf will be more busy than me during the Congress.
That is unlikely, Tom, but you are doing a wonderful job in organizing this fantastic Congress in Madrid, I think. The second question regarding the global guidelines, I would think that the ESC guidelines are certainly already substantially considered beyond Europe. But there is also a pilot project now to see for, let's say, low resource settings to make a document on what would be the first things that you should do in case you have limited resources. So we're actually trying to reflect also on different healthcare systems, and that not every healthcare system can afford every possible treatment. So we probably need to also develop ways of prioritizing what is the first things that you should do.
Thank you. Moving from the past to the present, we started with the past, now we are coming to the present, and we will also discuss the future towards the end of the dialogue. But coming to the present, Tom, what about the meeting in Madrid? You are a great innovator, both for the journal and also now for the Congress. And innovation is always important, not only in science, but also in organizing congresses. What will be the main innovations for the Congress in Madrid? What are your surprises you will show us in Madrid?
So, when we think about innovation with something so successful, so well developed and growing as ESC Congress, we have to be very careful with introducing various innovations to make sure that we do not break this wonderful growing plant. And that's why we are very careful, and we are trying to build and sort of respond to questions and things that the cardiology community has posted to us. So every year, as you know, our team within the ESC is collecting information about the Congress, about how participants have viewed the Congress, what were the strengths, what were the weaknesses of the Congress. And this data is very carefully analyzed by the Congress team, by other teams within the ESC. And from this, we can actually learn quite a lot how we need to improve and change the Congress in the future. And in Madrid, for example, one of the key elements that we are developing and introducing is ensuring that and this maybe I'm starting with something a little bit trivial, but something that bothers everyone, which is a sound management during the Congress. Because in many sessions, people have complained, we do not hear well. There were problems with sound during the Congress. So I hope that we will have solved this problem. We will see. I don't want to announce that we have solved it, but there are some very good solutions that are being introduced by the Congress team in order to make sure that the sound management will be perfect in all rooms, not only in some. But from the perspective of practical nature, we are, for example, expanding our digital cardiology element within the Congress to encompass artificial intelligence, because we are more and more aware that AI tools and AI is being broadly used. So the team responsible for development of the digital health and digital cardiology program is very much focused on this practical and on practicalities of this aspect. The other aspects that we are developing is we have decided in response to questions from people who told us, you said, Filippo, we need to speak about the future. So people said, when we come to the Congress, we want to learn about the future of cardiology. We want to learn about the novel therapies. There is a lot of progress happening within our field, and we want to see in a pill where we are going. And that's why we have decided to create an area within the Congress which we call Discovery Pole, where the future aspects of cardiology will be presented, and we hope this area will develop quite well. It will be very well sort of compiled and fit into the rest of the program. We are also creating various ways to watch our content. For example, we have learned and we have observed that during the previous Congress, quite a lot of participants, almost 60-70% of participants who are actually on site, are watching the content on their phones. So this is quite an interesting observation, is if you are on site, why you are watching on the phone. But that shows that people need different ways of accessing content, and we are building up and developing our app into more and more interactive modes, and building up the way that people can access the content. This also includes simple ways. We are creating a little bit more approaches to overflow rooms, where people who want to watch a certain aspect of guidelines, but they don't want to run across the whole convention center into the guideline room, they can watch this content in an overflow room that will be located closer to their to where they currently are. So there will be these sort of practical developments as well. We have also decided to introduce this year something more for building ESC and cardiology community. So within our sort of community area, we will have something called fireside chats, which will be a small or medium group meetings where we are able to facilitate very informal and very direct discussions, a bit like you have organized here today, between people involved in various aspects of development of cardiology, and this is co-organized with various working groups and councils of our society. And then you know, maybe all of these aspects are sort of underpinned by the fact that we are trying to constantly improve the way we organize the sessions themselves, regarding the length of the session, regarding the location of different elements and rooms within the Congress. So we, as you see, we are trying to innovate on all of these different levels and layers of our sort of Congress. But maybe the last thing that we have changed is we are creating more types of different presentations that people can deliver. This is aiming on trying to ensure that more abstracts are accepted from around the globe. I have to say that during the last Congress, I met with somebody from one of the smaller countries, and I said, well, you are complaining you do not have invitations for major talks and so on, but where are the abstracts from your country? I mean, you do not submit abstracts. If you do not submit abstracts, then how do you expect we are going to have your cardiologist featured as main feature in the Congress? This has to go in parent. They said, well, you know, 10, 15 years ago, we were submitting to the Congress quite a lot, but for the last 10 years, they were never accepted. So we thought we need to try to create more opportunities for people to present. And we are creating, for example, this form of presentation, which is called e-poster rounds. That will be a smaller version of presentation, but still giving people opportunity to share and discuss the research with colleagues. I guess this is it, quite a long list.
Well, congratulations. This is not innovation. This is a tsunami of innovation.
But they are all connected to each other. So,
yeah,
so it's all very small steps in something that's already there.
But it's really a nice package, and really enjoying listening to you. Ulf, back to guidelines from past to present. What will happen this year? Of course, you cannot give us details, but the broad picture. You're mute. Let's unmute.
Yes. No, it's fine. Thank you. So first of all, yes, I'm very much looking forward to the fire chats at the ESC, which is really a new, very nice feature, Tom. And yes, this year we will have new guidelines on myocarditis and pericarditis. So there have been guidelines before on pericarditis, but now it's the first time on myocarditis, and I do think will be very important to define this more clearly for clinical practice, and also to really give the diagnostic algorithms very clearly. So I cannot go into details, obviously, because this will be released only at the beginning of the ESC Congress, but I think this myocarditis guideline is an important one. We do have, as another highlight, I think the joint guideline for valvular heart disease. And I think management of valvular heart disease is one of the most innovative areas at present in cardiology with all the new treatment options, catheter-based treatment options for valvular heart disease. And I think it's also important that this guideline is jointly developed with our surgical colleagues. So really stressing also the heart team concept that we should discuss together the best option for the patient. But I think that will be highly expected on how the experts and all the reviewers actually recommend giving the new options in valvular heart disease now, how this should be handled in clinical practice. Another highlight, I think, will be a first document on mental health and cardiovascular disease. And we had different topics. For example, we had guidelines on cardio-oncology, and now this is a guideline that really brings together the question of the relevance and the management of mental health in the context of cardiovascular disease. And I think that will probably alert clinicians to this topic. So that's another, I think, a highlight of the meeting. We will have a guideline on updated guideline on cardiovascular disease during pregnancy. And of course, as you all know, that is a very difficult combination of cardiovascular disease in pregnancy. And I can assure you it's a very exciting document and will be very relevant for optimal management of these patients in clinical practice. And finally, we have a focused update in the area of dyslipidemia. The last dyslipidemia guidelines was 2019, and now we have an update based on the new trials that have been completed over the past years, the increasing diagnostic but also therapeutic options we have in dyslipidemia, which is of course one of the main risk factors we can manage to reduce the risk in our patients. So I'm really very confident that these guidelines, they are, from my point of view, developed in an excellent way. They will be illustrated in an excellent way, as we discussed before, and will really help to improve clinical practice in these different areas. And as I mentioned before, we can, because there's such a high workload in the development of these documents, and there's so much work going in, just think that the task force of more than 20 people writing the guideline, but then there are up to 100 reviewers commenting, and all these reviewer comments are then discussed in the task force, are implemented in the documents, and that's why we can produce 4 documents each year. But it is probably also a way these then are one of the highlights of the meeting. But as I'm really very much looking forward. I don't know, Filippo, if you allow me to answer a question in the chat.
Please,
Eloisa
yes,
has asked a very interesting question, and I mentioned the evaluation or the advanced presentation and evaluation of evidence for the guidelines. But now we are, of course, increasingly in the area of precision medicine, and Eloisa has asked whether we come from evidence-based medicine to precision personalized medicine. And there are areas in cardiology, and actually there's a document in development and focused update for cardiomyopathy, for example, where we really enter more and more the area of precision medicine. But I would argue that precision medicine also needs evidence. And what, from my point of view, is happening that we are getting more precise in the diagnosis. And if I take now the area of cardiomyopathies, I would take the example, for example, of TTR amyloidosis. We are getting better in the diagnosis. And you have actually trials in the range of 400 patients that show already an impact on mortality. So we have actually 2 trials in TTR amyloidosis. So I do think we should not... we should still consider evidence-based medicine, but precision medicine means that we get more precise in the diagnosis, and then the clinical trials can be smaller because they are really more targeted to the specific population.
Well, thank you. And now we have with us the president, Tom Lüscher. Welcome, Tom, to our dialogue. I started by saying that traditionally the protagonist of the dialogue is a famous cardiologist. But today the protagonist is not a person, but is the European Society of Cardiology, a society we all love. And today is a sort of celebration of the society with the 3 leaders. Tom Lüscher, Tom Guzik, and Ulf Landmesser. Now, so far, we have discussed past and present of guidelines and Congress. Then we will go to the future. But with you, to start with, we would like to discuss the past and present of the European Society of Cardiology. You wrote a wonderful editorial, From a Club of Friends to a Scientific Society. Can you tell us more about it?
Yes, we are actually in the fortunate situation to celebrate a birthday, an 75th birthday. So we're really a mature society, I would argue. And in fact, 75 years ago, the then Swedish president, Dr. Nillen, and two French people, Lenègre is the most famous one because he described the fibrosis of the conduction system and sudden deaths thereof. And then also John Parkinson from the Wolff Parkinson White syndrome, a very prominent London cardiologist, put everything together and had the first Congress in London at that very time. And of course, then it was, really a club of friends. They discussed whether to have a yearly Congress. Initially, they weren't there to do this. Then they didn't even dare to have a journal until a flamboyant person came along called Paul Hugenholtz, who said, we need a Congress every year. We need a journal and we need a heart house. And so then the heart house was built in Sophia Antipolis. And then when I was vice president with Jean-Pierre Basson, we saw that the tree of cardiology was growing as we speak, and we created associations. Initially, an association for rhythm disorders, the ERA, and then followed heart failure, prevention, acute cardiac care, nursing, and we have now 7 associations. And the backbone of the initial society, the working groups that are very scientific, they remain. We have 15 of them. And then we have something in between, which are our councils for cardio-oncology, for hypertension, and so on. And today, we just looked at all the data of, and that's why I'm late, apologies for that, the management group. We currently have 240 employees at the European Heart House and at our site in Brussels. So we're really a big society. We have a turnover of 65 million a year. We have 10 congresses, now 11 with cardio-oncology that just took place in Firenze. And we have 17 journals, and as of September 18, and we're planning also a new one, and not just EHJ valvular and structural heart disease, but also next year probably cardio-oncology, because this is really an evolving field. So the society is really blossoming. And today we discussed to expand the Brussels office, because Brussels is very important for certification. So, for instance, a major important topic for us is, can cardiologists also sign off MRIs and CTs? That's what we're working on. Then, of course, we want to expand research in the horizon. We want to have a real budget for the cardiovascular health plan. We talk to the European Medical Agency to make sure that we have proper access of novel, innovative drugs. And basically the same applies for devices. That's a bit more complicated in Europe with the notified bodies in all 27 countries. But it's not just the 27 European countries. We have 58 European countries that are part of our society. And we have 47 affiliated societies across the world. So we're really a global society. And global health is the topic of our Madrid Congress, where we celebrate the 75th birthday. And so we think we really made it as far as we can, and it's a very impressive society, and I'm privileged to be able to lead it in this interesting times.
Tom, thank you very much for this broad perspective. An important issue is advocacy. Cardiovascular disease remains the killer #1, but we have to do more because it's perhaps a bit underfunded. I know that this is a topic we are developing very brilliantly. Can you tell us more about it?
Yes, indeed. Since John Martin was vice president with me in the early 2000s, and he, for the first time, tried to get the ESC involved in the European Union. It was the Spanish presidency there, and he speaks Spanish because once he wanted to become a monk, then gave up on it. But he learned at least Spanish, and so he had very good relations to the Spanish health minister, but it never really evolved into a real plan. Now, in the last 3 years, we were able to go through the Hungarian presidency that took place last 6 months in 2024, thanks to Bella Merkley, rector and cardiologist of Semmelweis University, who could influence the government. We had a meeting in July in Budapest where a lot of politicians were present. And then on December 3rd last year, thanks to our efforts to influence with our friends, all 27 ministers of health across Europe, we were able that they approve the first cardiovascular health plan in the history of the European Union, really addressing the main killer across our countries. And now, of course, I'm drifted a little bit into politics. So I met the Minister of Health, which this is called the Commissioner of Health, Oliver Verhaly, already twice. I had meetings with DG Santé, Direction Santé, the Health Directorate. They are a whole group that actually will write this cardiovascular health plan. It's going to be a 5-year plan. And the oncology's got 4 billion, not million, 4 billion euros to run this. It will be a bit more difficult this time because of the war. You read the newspapers, everybody has to spend 5% for military. So this will have an impact. He suggested that there will be a 20% cut throughout for science. And of course, now when they discuss the budget as we speak in Brussels, they will first talk about the military, then about agriculture and some other things. We are number 6. But hopefully 6 or even 3 billions would be fine. Is not such a huge thing for the overall budget of the European Union. And Ursula von der Leyen said she wants to make Europe big again in research. She read Mario Draghi's report properly because that's exactly what he says. And so, we're working on this. And the DG Santé already came back to me, and I gave them a list of major topics that I think is important, such as aging, vascular dementia, cardiometabolic medicine, cardio-oncology, women's health, environment and the cardiovascular system, and also registries to allow for artificial intelligence. I should mention that Oliver Verhaly, the Commissioner of Health, is very much into AI, which fits very nicely with my own strategy. So we have had a very good, entertaining discussions twice now. And he is also very concerned about obesity, unhealthy food, unhealthy nutrition, unhealthy drinks. So I think also cardiometabolic medicine. I wrote another piece lately that just came out on Friday in the European Heart Journal, is something that we should really also consider center stage today.
So thank you for this broad perspective. And now, from past to present and now to the future. Let's start with Ulf and guidelines. What do you see in your crystal ball for the future? I'm sure that artificial intelligence will be important also in this direction. What can you tell us?
Yes, so absolutely. We are already using artificial intelligence now for literature research or for evidence research. As we mentioned, we have this, and Tom is a big supporter, we have this chatbot for the guidelines, so we can actually facilitate use of the guidelines. So, and clearly, artificial intelligence is a very important topic in the ESC, but also in the future for the guidelines. And it's actually something we are now working on. It's not so, it also poses new challenges and how we evaluate actually the evidence regarding the usefulness or the really capacity of AI-based approaches to improve diagnosis, improve clinical outcomes. So that is clearly for the current task force is an important challenge on how to evaluate these new developments so that we can really give guidance. We have the challenge that actually cardiology is really expanded. As Tom mentioned, we have new areas, cardio-oncology. We will have new guidelines coming up on heart and kidney disease. So we really are now getting also, or we are widening our scope basically towards interdisciplinary topics that are becoming increasingly important in our populations. So I would think the facilitation of use of recommendations of guidelines by AI for clinical practice will be an increasing, will be a possibility to actually augment implementation of guidelines, and also in the different areas of diagnosis, even of management, AI-based approaches will become more and more important, and that will be reflected in future guidelines.
Thank you very much. Tom, crystal ball for the future of the our Congress.
Well, I thought a lot about the future of cardiology at large. And I think the European Society of Cardiology has to embrace artificial intelligence, as pointed out by Ulf. I think this new technology will change our specialty more than anything else that we experienced in the last 2-3 decades. And the reason is that it sees what we don't see. For instance, in the ECG, we spend lots of time to learn how to read ECGs, which is, of course, an art. And our previous generation learned how to listen to any sound of the heart to diagnose any condition that you can think of. And then came echo. And today, my fellows at the clinic, they don't even wear an echo and a stethoscope, I noticed, because they trust much more the echocardiography. Now, for ECG, as we learned from Paul Friedman's work and now from work of many others, that in fact the AI algorithms, they see more. They see for 10 beats, they see that this is a male with 8 years of age that had atrial fibrillation in the past, has left ventricular dysfunction, and has amyloid heart disease. And just like this. So I think the ECG will be less of an important competence, and imaging also will be largely taken over by artificial intelligence. So what is actually left for us, and I wrote a piece about this, so we need a new profile of the cardiologist. The cardiologist should be really knowledgeable about the AI technology, about IT, about data science, about basic statistics to judge what he's using to be sure that an algorithm is properly evaluated, verified in other countries, in other cohorts, so that it is valid, because an algorithm can kill patients as can a bad device or a drug with side effects. So in manual disciplines such as PCI, valvular interventions, interventional echo together with people doing clipping, operators, and electrophysiologists. They will become better and faster with AI. They will get the information integrated quickly. They will see what sort of where the problem is to ablate much quicker than they can today. They might have holograms on top of the table in the cath lab. They will, and this is already a reality. They integrate OCT with the angiogram. You can select the right stent. So I think it will make us more precise, faster, and will allow us to have more time to talk with the patient. And this is actually important because in the randomized trials, we look worse than avatars in terms of empathy and the right answers. So we have to take more time to be nice to the patient. So to ask them, did you understand? Did you understand what I told you? Because 60% of the patients don't remember what we told them because we're so fast rushing to the next one. So I think this will help us a lot to be better doctors eventually.
I think it will be, in a way, in line with the statement that AI will not substitute cardiologists, but cardiologists that use AI will substitute the ones that don't use it. And I think Congress that we have will also follow these developments, and it will need to become part of a continuous learning ecosystem that is personalized, easily accessible to our participants. And the way we organize Congress also needs to change. I mean, if a war can be run by AI systems, then a Congress can be run much more easily. So I think that maybe some development and development of tools to help us both develop programs and run the Congress per se, I think is in the future for us. Thematically, I think we need to broaden, become more inclusive and representative, encompass data scientists, engineers, because these areas of life are becoming inherent part of medicine. So I think this is the future of the Congress needs to reflect the future of cardiology that Tom so nicely outlined.
You know, Tom, what we did today to put together the hotlines and to look for chairpersons and discuss, and next time around the AI will do it, and maybe you're the last CPT chair that is really not.
Yeah, I think that there are systems already available to run hospitals. So,
Yes.
So the Cleveland Clinic is apparently utilizing one of the large industry systems that is also used by military to help them organize the patient flow. So I think you are right that this is going to be very helpful to us, and it may help us develop Congress much more efficiently. But I still hope that our knowledge will be necessary, and people who use AI will just win with people who don't.
So, Filippo, if I may ask you something. So, how do we make sure that we don't have faked documents in the journals? Because, as you know well, we're going to publish a paper with Holger Thiele and his collaborator, where they submitted actually 20, if I remember well, abstracts to the German Society of Cardiology and send them for review. And they got actually very good reviews, not distinguishable from. And they also used the new GPT-0 that is detecting actually texts produced by an avatar. How do you look at this, Filippo, as an editor?
Well, of course, it's challenging also because it's a quickly developing scenario. Now we are tools able to detect if text is produced by GTP. So it's artificial intelligence versus artificial intelligence in a sense. But definitely, we must be very vigilant because data fabrication with artificial intelligence becomes easier. I think we have tools. We are working on that with our publisher and with the society. It's challenging, but I think that we'll manage to disseminate the correct information. Coming back to the future of the European Society of Cardiology, I think that, well, assuming that artificial intelligence is already a co-pilot, let's hope will not be the unique pilot, but a good co-pilot. The other co-pilot is the cardiologist. And we tend to focus on specialists or super specialists, while I think that the role for the general cardiologist is perhaps becoming more and more important. What are your feelings, and how do you think the role of the general cardiologist can be, let's say, better implemented in the future?
You know, I just wrote this piece about this that you were kindly publishing in the European Heart Journal. I think that we saw initially what we called internal medicine grew like a tree into different specialties. And then cardiology was the next tree that, and some of my key colleagues, they only implant TAVI valves all day long. And so what is actually a general cardiologist that still has a bit of an overview? And I think cardiometabolic medicine brings us together again, because what it means is one of the major health problems we have is the increase in body weight, obesity at the world at large. And this drives, as you know well, diabetes, it drives inflammation, it changes the microbiome, it impairs renal function, it increases blood pressure, it induces fatty liver disease. All these different organs work together in an unfavorable fashion on the heart, producing HFpEF, HFrEF, myocardial infarction, stroke, and cardiovascular death. So we as cardiologists need colleagues that focus on this integration of these different organs into a specialty that I would call cardiovascular or cardiometabolic medicine. And this is actually getting very interesting as we have now means to treat it. We have GLP-1s, GLP-1 GIPs that work on the liver, on the kidneys, on the inflammation in the belly, in the adipocytes. We have also sodium glucose transport inhibitors that are good for diabetes, for the kidney as well as for heart failure. We have non-steroidal mineralocorticoid antagonists that work in the kidney. They work for blood pressure and they work for heart failure. So we have a new integration that is sort of a dialectic, if I may say so, development after decades of specialization that is an opportunity for generalists.
Well, thank you very much for this perspective again. Well, I think it's been really an enjoyable hour, very instructive, and which is spanning from the past to the future. I think that we are today properly celebrating our society with three leaders of the society, Ulf, Tom Guzik, Tom Lüscher. Thank you very much for your participation. I think it's been really an entertaining and useful hour for all of us. Of course, the last word is always to President. So, Mr. President, the last remark from you.
Well, the last remark is you are also a leader of the European Society of Cardiology. And congratulations on this journal family. That's a fantastic body that is so important for the reach of our society and for our strategic aim to provide solid and certified information to our members. So thank you for that. Filippo. Good job.
The challenge and the goal for all of us is to reduce the burden of cardiovascular disease. And I think that we are progressing very well in this direction. Now, thank you again to all of you for your participation. Next dialogue, because we never stop, also in summer. So next dialogue will be on the 31st of July, as usual, Thursday at 17 CET. And next time, for the first time, we have a guest from China, Professor Shangsheng Ma. As you know, the progress of cardiology in China is massive, is really amazing. We received many interesting manuscripts from China. So next time, the protagonist of the dialogue will be a Chinese colleague. Thank you very much again, and we'll stay in touch. And we will meet next month here and in August in Madrid. Thank you very much.